You know, um, there's a medical scenario in our sources today that is, well, it's genuinely chilling.
Yeah, mostly because of how completely ordinary it sounds.
Yeah, exactly. So a 58-year-old man walks into his doctor's office. He's been noticing, some changes in his bathroom habits over the last 3 months.
Just a little bit of rectal bleeding.
Right. Nothing agonizing, just different. And the doctor listens, nods, tells him it's probably just hemorrhoids, and sends him home with a simple cream.
Which is, I mean, a very common interaction. We see that symptom profile presented in primary care clinics thousands of times a day.
But here is the reality of this specific case. It wasn't hemorrhoids.
Not at all.
That man had a near-obstructing cancer sitting 30 centimeters up in his sigmoid colon.
Yeah, that contrast is staggering.
It really is. And that contrast between a harmless tube of cream and a life-threatening tumor is the exact mission of our deep dive today. We're looking at colorectal cancer, specifically how we miss it and how we beat it.
Because the stakes here are incredibly high for you and everyone listening. Colorectal cancer is currently the third most common cancer globally.
Right. And the second leading cause of cancer death.
Exactly. And when you break down the anatomical data, roughly 50 to 55% of all these cancers set up shop in just two specific connected areas, the sigmoid colon and the rectum.
Okay, so let's unpack this. Because the phrase, it's probably just piles or just hemorrhoids, that might actually be the most dangerous combination of words in modern medicine.
I'd completely agree with that.
The difference between catching this disease early, when it's highly treatable, and catching it late comes down entirely to how critically we think about these everyday symptoms.
We have to look past the obvious, easy answers. The clinical thinking has to be sharp because the consequences of a misdiagnosis, well, they alter a patient's entire trajectory.
So to start, I want to figure out why this specific piece of our anatomy is such a magnet for cancer. We're talking about the sigmoid colon.
Yeah, for those visualizing, it's this 35 to 40 centimeter S-shaped segment of the lower intestine.
Situated down on the left side of your abdomen, right? Why is that specific spot so vulnerable?
It is driven by pure biology. There are three distinct physiological reasons why cancer thrives there.
Okay, what's the first one?
The first major factor is fecal stasis.
Meaning things are just sitting still in that S-curve.
Yeah, basically, if you look at the right side of your colon, the ascending colon, the waste there is still largely liquid and moving fairly consistently.
Okay.
But by the time waste reaches the sigmoid on the left side, water has been absorbed. It's fully formed stool, and the sigmoid acts as a holding chamber.
So it just waits there before evacuation.
Right. And because it sits there for hours or sometimes days, the lining of the colon, the mucosa, is subjected to prolonged physical contact with whatever carcinogens are trapped in that waste.
Oh, wow. What kind of carcinogens are we talking about?
Well, a primary example would be heterocyclic amines.
Heterocyclic amines, what are those?
They're chemical compounds formed when you cook processed or red meats at high temperatures.
It's like grilling a hot dog or something.
Exactly. When waste just sits in the sigmoid, those chemicals have ample time to interact with the cells lining the colon, creating oxidative stress and damaging DNA.
So the tissue is literally just soaking in the bad stuff.
It is. And that prolonged exposure brings us to the second factor, which is the bacterial environment.
The microbiome kind of thing.
Yes. The sigmoid has the highest concentration of anaerobic bacteria in the entire gut. And these bacteria aren't passive.
What are they doing?
They actively metabolize primary bile salts, which your liver produces to digest fats, and they convert them into secondary bile acids.
And what do secondary bile acids do? Are they bad?
Very. They are highly toxic to the cells lining the colon. They act as known co-carcinogens.
Wait, really?
Yeah, they break down cell membranes and cause further DNA damage. So you have environmental carcinogens from diet, plus biological carcinogens manufactured right there by your own gut bacteria.
That is wild. The bacteria are actively synthesizing a cancer-promoting environment.
Exactly. Then you add the third piece of the puzzle, which is the tissue itself.
What's wrong with the tissue?
Well, because fully formed, solid stool is rough and abrasive, the epithelial cells lining the sigmoid colon undergo significant mechanical wear and tear.
Ah, so they get scraped up.
Right. To compensate, they have the highest rate of turnover in the gut. They're constantly shedding and regenerating to repair the lining.
And every time a cell copies itself to rebuild that lining, there's a chance for a typo, a mutation.
Precisely. More cell division mathematically guarantees more opportunities for replicative errors.
That makes total sense.
If we step back and look at the anatomy, you have a high turnover tissue bathing in a concentrated, stagnant pool of chemical and bacterial carcinogens. That's why the sigmoid is ground zero.
It almost makes you think of the sigmoid colon like a slow-moving, backed-up garbage chute in an apartment building.
That's a really good way to put it.
Yeah, the trash is just sitting there way too long. The bacteria are basically throwing a party, and the walls of the chute are constantly having to repair themselves under all this stress.
It's the absolute perfect setup for biological mistakes to happen. It is literally a factory for cellular stress.
Okay, so if the sigmoid is this high-stress mutation factory, my next question is about the timeline. How fast do these mistakes turn deadly?
Well, you hear cancer and you instantly think of this aggressive, fast-moving wildfire,
Yeah,
right?
totally. It sounds immediate.
But that slowness is actually our single greatest advantage with this specific disease.
Slowness. How slow?
We refer to it as the adenoma-carcinoma sequence. The multi-hit model of colorectal cancer demonstrates that it takes 10 to 15 years for a normal colon cell to transform into an invasive cancer.
Way of getting stuck here. 10 to 15 years?
Yes, a full decade or more.
If we have a 10 to 15-year head start, a decade and a half where this thing is just sitting there, shouldn't a standard yearly physical catch this? Are doctors just not feeling for it, or is standard blood work completely useless here?
Standard blood work is notoriously poor at catching this early.
Why is that?
Because a localized premalignant polyp doesn't shed obvious markers into your bloodstream that a routine metabolic panel would pick up. It's a very localized structural problem at first.
So it's completely under the radar of a normal checkup.
It really is. The sequence is a very predictable, multi-step series of genetic failures within the tissue itself.
How does it start?
It usually begins with a mutation in a gene called the APC gene. Think of the ATC gene as the cell's brake pedal for division.
Okay, so when that gene mutates and fails.
The cell loses its brakes. It starts dividing abnormally, forming a benign polyp called an adenoma.
When you say adenoma, we're just talking about like a little fleshy bump on the wall of the colon?
Essentially, yes. It's an overgrowth of tissue protruding into the tube. At this stage, it is not cancer. It cannot spread to other organs.
Good to know. But it doesn't stay harmless forever.
No. As years go by, that polyp takes more genetic hits. The next hit is often a mutation in the KRAS gene.
KRAS, what does that one do?
If APC was the broken brake pedal, a mutated KRAS gene is like a brick jammed onto the gas pedal. It forces the cells to grow and replicate even faster.
Oh, wow. So it's growing rapidly, but it's still contained in that bump.
Correct. The final fatal blow is usually a mutation in the TP53 gene.
What's TP53?
We call TP53 the guardian of the genome. In a healthy body, if a cell's DNA is severely damaged, TP53 forces that cell to self-destruct.
Like a built-in self-destruct button.
Yes, a process called apoptosis. It's a safety mechanism, but when the TP53 gene mutates and fails, that safety mechanism is gone.
So the cells become immortal.
Exactly. The immortal, heavily mutated cells break through the lining of the colon. That benign polyp has now transformed into invasive carcinoma.
That sequence is fascinating. But if blood tests miss it, how do we gauge the danger of a polyp if we happen to find one?
The risk is directly tied to a very simple visual metric. We call it the size rule.
The size rule. So bigger is worse.
Precisely. If an adenoma is under 1 centimeter, the statistical chance that it harbors a malignancy is less than 1%.
Okay, that's pretty low.
But as it continues to grow unchecked, the risk skyrockets. Once an adenoma crosses the 2-centimeter mark, the risk of it containing malignant cells shoots up to 30 to 50%.
Wow. So a doctor just going in and snipping off that fleshy bump while it's small.
Well, you break this sequence entirely. If you remove the adenoma, the cancer never materializes. You've neutralized the threat.
Which brings us to a massive problem. Because that 15-year window doesn't show up on a routine blood test, we end up relying on symptoms to tell us something is wrong.
And that's where things get tricky.
Right. Based on the sources, the symptoms of sigmoid cancer are almost deviously easy to misread.
We have to think about the physical space inside the sigmoid colon. It is relatively narrow compared to the right side of the colon.
The garbage chute is narrow, and the trash bags are full, basically.
Exactly. When a tumor grows on the wall of a narrow tube, it physically encroaches on the open space. It creates an obstruction.
So it blocks things up.
Yes. The symptoms patients feel are obstructive. You rarely get generalized, vague stomach pain early on. Instead, patients experience alternating constipation and loose stools.
Alternating. Why alternating?
Well, the solid stool struggles to pass the tumor, causing constipation. Eventually, only liquid waste can squeeze past, resulting in sudden bouts of loose stools.
Oh, I see. And the sources mention stool shape changing too. Pencil thin or ribbon-like stools.
That's the mechanical reality of a blockage. The tumor is essentially acting like a rigid extruder.
Like a Play-Doh machine.
Sort of, yes. Waste is being physically squeezed past a narrowing gap, forcing it into that thin shape.
But the narrowing of the tube only explains the change in shape. The real trap for patients and doctors is what happens when that mass starts to erode.
Yes, the bleeding.
Right. This circles back to our 58-year-old man from the beginning. He saw blood, the doctor said hemorrhoids. How do you tell the difference?
It comes down to plumbing and transit time. Hemorrhoids are swollen veins right at the very end of the digestive tract at the exit.
Okay.
So if they bleed during a bowel movement, the blood is fresh, bright red, and it sits entirely on the surface of the stool, or you just see it on the toilet paper.
Because the bleeding happened at the absolute last second before the stool hit the bowl.
Exactly. But a sigmoid cancer is located higher up in the colon. As the solid stool scrapes past the friable, fragile tumor tissue, it causes the tumor to bleed.
And then it has to travel the rest of the way down.
Right. As that stool continues its journey down to the rectum, the blood has time to mix into the waste. It oxidizes slightly, becoming a darker red or maroon color.
And it is physically mixed inside the stool, not just painted on the outside.
That is an important clue, and I have to issue a massive warning here. Cancer and hemorrhoids routinely coexist.
Oh, wow.
Yeah.
So you could have hemorrhoids that are genuinely bleeding, giving you bright red blood on the paper, making you think you're fine.
While a tumor is silently growing higher up.
That is the ultimate clinical trap. A doctor sees the hemorrhoids, solves the immediate mystery, and stops looking.
That's why you can never just accept hemorrhoids as the final answer without looking deeper, especially if you are over 40. There are absolute red flags you must never ignore.
Like what? What should people look out for?
Unexplained iron deficiency anemia is a major one.
Because the tumor might be slowly oozing blood internally for months, depleting your iron stores without you ever seeing blood in the bowl.
Precisely. Unexplained weight loss is another alarm. And a very specific, highly distressing symptom called tenesmus.
Tenesmus. What exactly does that feel like?
It's the persistent, urgent feeling of an incomplete evacuation. The sensation that you still need to go to the bathroom even when your bowel is completely empty.
That sounds awful. Why does that happen?
What's happening anatomically is that the bulky tumor is pressing against the stretch receptors in the wall of your sigmoid or rectum.
That is incredibly deceptive. The tumor is essentially tricking your nervous system into thinking there is normal waste waiting to be expelled.
Your brain is receiving a false signal. So if you experience persistent bleeding, tenesmus, weight loss, or unexplained anemia, those are the red flags requiring immediate investigation.
Okay, so let's say the alarms go off, the doctor doesn't brush it off, they order the gold standard investigation, which is a full colonoscopy, right?
Yes, absolutely.
They go in with a camera, they see the whole colon, they find the tumor. What happens next? How do we stop it once it's there?
In stages 1, 2, and 3, colorectal cancer is a highly curable disease. But the cure relies entirely on surgical philosophy. It is all about the technique of removal.
How so? Isn't it just a matter of, cutting the bad piece of tubing out and stitching the two good ends back together?
It requires far more sophistication than a simple cut and paste. A modern colorectal surgeon performs what's called a complete mesocolic excision, or CME.
Okay, a CME, how's that different?
Often this is done laparoscopically, using tiny incisions and cameras. The fundamental principle of a CME is that you remove the diseased segment of the colon along with its entire intact mesentery following embryological tissue planes.
Embryological tissue planes. That sounds complicated. What does that actually mean in practice?
Well, when you are a developing embryo, your organs form inside distinct anatomical envelopes or layers of connective tissue.
Okay, I'm following.
Surgeons use these natural envelopes to their advantage. A CME means the surgeon carefully navigates between these original layers, lifting the organ and its surrounding tissue out intact without breaching the envelope.
Oh, I see. So it's like removing a diseased weed from a garden. If you just grab the stem and pull, it snaps, and the roots are still in the soil. The weed grows back. The colon is the stem, and the mesentery is the root system holding the blood vessels and the lymph nodes. If you just chop the colon out, you leave the potentially infected lymph nodes behind.
That perfectly illustrates the danger. Cancer travels through the lymphatic system.
So a complete mesocolic excision means the surgeon is carefully taking their shovel, going wide, and digging out the entire intact block of soil around the weed.
Right. You take the whole root system, so there's zero chance you leave a microscopic seed behind in the patient.
And how do they know they got it all?
To prove they successfully removed the entire root system, the pathology lab will examine that block of tissue and count the lymph nodes inside it.
Is there a specific number they need to find?
Yes. The international gold standard dictates that a minimum of 12 lymph nodes must be harvested and examined.
Why 12? Why is that the magic number?
It comes down to statistical probability. Extensive clinical studies have shown that if a surgeon extracts at least 12 lymph nodes and the pathologist confirms all 12 are completely free of cancer cells,
Then what?
the mathematical probability that the cancer is spread to a 13th or 14th node drops to near zero. 12 is the statistical threshold for confident, accurate staging.
Wow. If you find 12 clean nodes, you can confidently tell the patient, we got it all.
Precisely.
That level of statistical precision is incredible. But what about the people who don't catch it early? The sources mention that 20 to 30% of patients arrive at the hospital in a state of absolute emergency.
Yeah, that happens a lot. They don't have a slow change in bowel habits. They have a total sudden blockage.
And that's dangerous, right?
An obstructing tumor is a life-threatening crisis. The bowel above the blockage dilates dangerously and can perforate.
Oh my God. What do they do?
Historically, that required emergency open abdominal surgery, which carries massive mortality risks and often leaves the patient with a permanent colostomy bag.
But there's a better way now.
Yes, there is a modern technique that bridges this gap.
Bridging the emergency. What do they do?
For a suitable patient, a gastroenterologist can go in with an endoscope and deploy a SEMS. That's a self-expanding metal stent.
A stent. Where do they put it?
Directly through the center of the obstructing tumor.
Like pushing a collapsed metal spring into a clogged pipe and then letting it forcefully expand open.
That is the exact mechanism. The mesh stent pushes the tumor tissue aside and props the colon open. The obstruction is relieved immediately.
That's amazing.
The patient can evacuate waste normally, they can eat, and the severe tissue swelling goes down.
So they don't have to do the huge emergency surgery right then.
Exactly. What you've achieved is converting a terrifying, high-risk midnight emergency surgery into a calm, elective procedure scheduled for a few weeks later when the patient is stable.
It's incredible that we have the engineering to bail us out of an emergency like that. But nobody wants a metal stent pushed through a tumor if they can avoid it.
Obviously not.
Which brings us to the preventative side. What accelerates this biological clock, and how do we protect ourselves?
The risk factors are well defined, and they largely center around metabolic health and dietary environment. We discussed diets high in red and processed meats earlier, but beyond that, type 2 diabetes is a massive risk factor.
Let's dig into that. Why does diabetes, which is fundamentally, a blood sugar issue, increase the risk of colon cancer?
The mechanism links back to insulin resistance. When your cells resist insulin, your pancreas has to pump out higher and higher levels of it to force your blood sugar down.
Okay, so you have all this extra insulin floating around.
Yes, that excess circulating insulin promotes specific signaling pathways in your body, most notably one called IGF-1, or insulin-like growth factor 1.
What does IGF-1 do?
It acts as a loud biological signal shouting at your colonic epithelial cells to proliferate, to divide faster.
And going back to the beginning, faster cell division means more chances for those genetic typos.
Exactly. You are turning up the speed on the mutation factory.
That makes perfect sense. Are there other big risks?
Another critical factor is obesity. Adipose tissue, fat tissue, isn't just an inert storage site for calories. It is an active endocrine organ.
Meaning it produces hormones and stuff?
Yes. Excess visceral fat continuously pumps out inflammatory cytokines into your bloodstream. This creates a state of chronic, low-grade systemic inflammation.
And inflammation is bad for cancer.
Highly conducive to tumor growth, yes.
The sources also mention smoking. I always associate smoking with lung cancer, not the gut.
Right. But when you inhale tobacco smoke, you are also swallowing a significant amount of carcinogens in your saliva.
Oh.
Never thought of that. Those chemicals travel through the digestive tract, reach the colon, and have been shown to directly cause the specific genetic mutations, like the KRAS mutation, that accelerate polyp growth.
Man, Okay, on the flip side, we have protective factors. The sources highlight high-fiber diets.
Yes, fiber acts mechanistically like a broom moving waste quickly through the colon.
Reducing that stasis time we talked about.
Exactly, and physically diluting the concentration of carcinogens against the colon wall.
There's also data showing that regular aspirin use reduces the recurrence of adenomas. Why is that?
Aspirin operates by inhibiting specific inflammatory pathways, essentially cooling down the inflammatory environment that polyps need to thrive.
So it all comes back to the environment we create in the gut
Absolutely.
and recognizing that we have a massive advantage. We have that 10 to 15-year window. The adenoma-carcinoma sequence isn't just medical trivia. It's an actionable timeline.
It really is. Screening isn't just about finding cancer so we can treat it. Screening is literally interrupting the biology.
That is the core takeaway. Tell me about the FIT test.
When a patient uses an annual FIT test, fecal immunochemical test, they aren't just checking for visual blood.
Right, because we know the blood can be hidden.
The FIT test uses specific antibodies to hunt for hidden microscopic human hemoglobin proteins in the stool, which are often shed by large premalignant polyps.
And if it's positive, you get a colonoscopy.
Exactly. A colonoscopy allows the doctor to visually inspect the lining. When they locate a benign polyp and remove it, the cancer never happens.
It's the closest thing we have to a time machine in medicine. You go in, snip the polyp, and erase the future tumor.
That understanding of the timeline is what gives patients power over this disease.
Let's bring this all together.
Yeah.
If there's one golden rule, one non-negotiable takeaway from all these medical sources today for you, it is this. Never accept hemorrhoids as a default diagnosis if you are experiencing red flags.
Never.
If you have a change in bowel habits, unexplained weight loss, or persistent bleeding, do not just buy the cream and hope for the best.
You have to advocate for yourself.
We have a 15-year window to catch this, but the clock only matters if you are paying attention to the alarm.
It requires maintaining the right level of clinical suspicion. Don't let a common symptom mask a complex disease.
Before we wrap up, there's one final, somewhat unsettling thought from the data that I want to leave you with to mull over.
This is the part that really concerns researchers.
Right. We've talked extensively about this multi-hit sequence taking 10 to 15 years.
Yeah.
Because of that long timeline, sporadic colorectal cancer has historically been a disease of people in their 60s and 70s.
Right, it takes a long time to develop.
But the global data right now shows an alarming, undeniable rise in colorectal cancer in young patients, people in their 30s and early 40s.
It's a huge shift.
If the biological clock fundamentally takes 15 years to tick down from a normal cell to a deadly tumor, it means the genetic hits in these patients are starting in their late teens or early 20s.
It's just terrifying.
It begs the question, what modern dietary, environmental, or lifestyle factors are fundamentally accelerating that timeline in younger generations before they even reach the routine screening age?
Something is definitely hitting the fast-forward button on human biology.
It really is. Well, share this deep dive with your friends, your family, anyone who might brush off a symptom that needs a second look. Thanks for joining us, and we'll catch you on the next deep dive.